My topic for today, I've got two topics. One is non-operative management in sports injuries, as well as exercise in chronic diseases, or we also call them non-communicable diseases. I will try to do justice by incorporating both these talks in a very generalized manner. So let's see. What we know is non-surgical management of sports injuries is definitely more in number compared to surgical interventions, and it involves a wide range of modalities from pain management, physical therapies, bracing, as well as using injectables. Now, some of the common sports injuries that we see uh, in when we partake in any amount of physical activities, the most common are the sprains and strains, and on and off you do get fractures. One might think that fractures need surgical intervention. Not all fractures need surgical intervention. The undisplaced one can be managed conservatively. Now, what is the problem when we get injured? We immediately we suffer with pain, swelling, limitation in range of motion, and these things cause deleterious effects generally, where there will be muscle inhibition, decrease in strength, and affecting our daily lives, not just impairing our sports performance. Now, although in my slide it's written that activities such as running, basketball, and tennis are high prevalence in sports injuries, but what I always tell everyone is there is no such thing as participating in sporting activities or physical activities and not getting injured. Somewhere down the line, you are bound to get injured. Musculoskeletal problems will happen to you, to me, to all of us. There is only one way that you can prevent injury, that is sit at home and do nothing. But sitting at home and doing nothing, you risk of yourself of getting all other problems as well. So it's basically, you can't really run away from this. Hence, knowing what to do is the most important thing. Now, what are the benefits of non-surgical approach, which we also call conservative management? Um, it allows us to recover faster. We don't undergo the knife. Not just you. When I have a problem, I myself am in a lot of denial because I don't want to undergo the knife. It is definitely less invasive, and because it is less invasive, if done properly, the recovery time is much faster compared to surgery. Now, one of the single most important component in conservative management is physical therapy and rehabilitation. So what actually happens, we see you, we assess you, we decide what to do. Our physiotherapy colleagues come on board, and they adhere the various different type of physiotherapy modalities which are available. Along the way, we progress, we monitor, and we step up the game. Now, before I go into further details, let's look at some of the definitions. We have all heard the word rehabilitation, but actually there are multiple terms here. One is prehab. Prehab is generally prevention of an injury before it happens. Like I say, you cannot 100% prevent an injury, but you can do what is required to reduce the likelihood of sustaining an injury. Then you have pre-rehab, which is pre-operative rehabilitation. Today, science have evolved to such a level that even the surgeons today realize that pre-operative rehabilitation is very, very important to get optimum outcomes post-surgery. And of course, rehabilitation itself, which can be post-injury rehabilitation or post-operative rehabilitation. Now, what are some of our goals of rehabilitation? It is basically to prevent adverse effects from an injury. You want to facilitate some amount of tissue healing, re-establish the neuromuscular control, improving flexibility, obtaining a normal range of motion, regaining muscle strength, uh, getting good balance, and not forgetting maintaining our fitness. The biggest problem that we all face is when we get injured and we are told to rest, but we are afraid to rest because if we rest, we're going to eat and put on weight. So, looking at this component itself is epitome in rehabilitation to maintain some amount of fitness. I do have problems with this when I have to deal with an elite athlete because they cannot afford to lose fitness during a rehabilitation process. So there's something that we often do call activity modification. Hence, if you injure your lower limb, while rehabilitating the lower limb, I will allow some amount of exercise that involves the upper limb instead to maintain the fitness levels. Now, very generally, this is sort of an algorithm of principles of rehabilitation where we start with activating back a muscle which is inhibited and then working on the balance. Proprioception is very simply synonymous as balance, strength of the muscle, flexibility of the joints and muscles, moving up back to skill acquisition or sport specific training, and ultimately returning back to sports. Now, why I always say sports is, and I think Nazri would agree with me, a wonderful branch of orthopedics, interesting, very, very challenging, because it is one of those fields where we don't just send someone out or back, but we try to send them back to pre-injury levels. Hence, that is the ultimate challenge. It's not just treating something and making him independent. It's much, much more than that. Among us, it is also the same. If you like to hike and you get injured, our responsibility is try to work together so that you can go back hiking. So that is the greatest challenge that we face. Now, when does rehab actually start? Immediately, as soon as an injury happens, or as soon as after a surgery. Whether it's an injury or whether it's a surgery, the first things that happen are always pain, inflammation, swellings. And starting rehab early can avoid the detrimental effects such as muscle atrophy and deconditioning. What do we do? I'm sure we are well aware of the term RICE, right? RICE as ice compression elevation. But more recently now, we speak of something called PRICE-M, where the P stands for protection of the injured site, then the usual RICE, rest, ice, compression, elevation, and if required, medications. The medications that we tend to play with after an injury is also something that I try to educate my patients, because a lot of them, when we try to prescribe something, it's a taboo. Nobody wants to take painkillers because painkillers is a problem. But there are various types of painkillers. So if I think that you have inflammation and I want to quieten down the inflammation, I would prescribe you a medication to quieten down the inflammation, which is non-steroidal anti-inflammatory medications, but it's also a painkiller. So ultimately, it's important to understand what causes the pain. If the pain is because of an inflammation, then I will want to quieten down the inflammation. If the pain is because of a nerve problem, then giving an non-steroidal anti-inflammatory medication is just cheating ourselves, because you trick your brain by not feeling pain, but you're actually not really doing anything. For that, you will want a medication to tackle the nerve problem, which is a different type of a painkiller altogether. All right. Using in of brace and supports have become rather popular these days, where it plays an important role in rehabilitation, whether it is post-injury or post-surgery. Now, it functions mainly to stabilize the injured part, at the same time prevent further damage and more injuries uh, to the involved joint. There are various different type of braces available. It is beyond the stock for me to go into each and every one. So what I would do is we will pick something which is so common among all of us, not just in athletes, but it happens, we have all perhaps experienced this at some point of time in our life. A simple ankle sprain due to an inversion injury. In the past, when there is an ankle sprain and there is a swelling and you go to the hospital, after physical assessment, the first thing you do is an x-ray. The x-ray shows no fracture, but you are in pain. The ankle is swollen, you can't really step. What was practiced in the distant past was putting sort of a back slap or a half POP kind of thing to immobilize the ankle so that the swelling reduces, hence pain comes down, and then you will be assessed after perhaps a couple of weeks. Once everything settles, you remove that back slap and move on from there. Today, we don't really do it. I personally don't use the back slap unless there is a broken bone, right? So, because when you use the back slap, yes, you get to achieve what you want, which is to reduce the swelling, but you also cause a lot of other problems, such as joint stiffness. Imagine not moving your joint completely for a couple of weeks. After that, you will have headache to mobilize the joint, number one. Number two, when a joint is immobilized, within 6 hours itself, glycogen synthesis, a process that happens in our body, starts to stop. And then you start having muscle disuse, atrophy, strength drops. And imagine it happens on a daily basis. Imagine what actually happens after 2 weeks. So the rehab becomes very complicated. So what we tend to do these days is, when there is an ankle sprain, we put this bracing or supports. This is called an ankle stirrup. So what we want to do is protect the joint to prevent further inversions of the joint. So you have something more rigid that goes around like that, which doesn't completely immobilize the ankle, but it does its job by preventing further inversion and eversion. Gone are the days that I will say 2 weeks use crutches that don't stop. It's no more like that today. Today it is controlled weight bearing. Hence, maybe for the first 48 to 72 hours, you don't weight bear, you can walk with the aid of crutches. But once the pain and swelling comes down, you are able to weight bear as tolerated. So you don't want, it's no more putting a cement, using the crutches and see 2 weeks later. Things have changed these days. A more regular visit to your doctor, your therapist, because they play a pivotal role itself in helping us manage. And this is one type. This is another type of an ankle immobilizer, which also has a similar effect to reduce the joint from moving too much, at the same time preventing inversion injuries and helping with the swelling reduction. Sometimes I tend to use this as well, a boot walker. So you immobilize the joint and ask the patient to walk on the boot walker. Now the boot walker's concept is generally non-weight bearing. So you allow them to walk. But it's not as simple as this picture, because there's an elevation here. Then the whole level between the right and the left leg will be different. So there is another type of pad you put on the other leg shoe so that you raise the levels to be equal. And the patient becomes mobile. He doesn't need to be bedridden, and it will achieve what you want to achieve. Now, what we do also know in an ankle sprain, I'm sure we have all heard this term, once an ankle sprain, always an ankle sprain. It's because there is high risk of recurrent sprain, and studies have shown it can be increased risk of recurrent sprains for 12 months, almost a year. And every time you sprain it again and again, it causes a lot of other problems that can affect the cartilage, which is a covering of the bone. It can injure the tendons, it can injure the other ligaments and whatnot. Hence, once everything quietens down, I tend to put this, which you call a functional ankle support immobilizer. It's not as rigid as what you see here. It's more flexible. It allows range of motion, and the word functional lateral immobilizer, lateral means outwards, because you want to prevent inversion injuries. It's quite comfortable to be worn with shoes as well. So you can wear this and go back to work, go back to running when you are ready, while rehabilitating to work on other things as well. So today, bracing has become so important. You have rigid braces and functional braces for almost most if not all injuries, including the knee. You have functional bracing. I didn't really, like I say, I can't do each thing because it's beyond this. But I had this is an elite athlete who had a posterior cruciate ligament, or a PCL. We have all heard of ACLs, right? Which is in front of the knee. A PCL is at the back, right? Who had a complete tear. This was an elite level athlete. And it was only that one ligament which is torn. Of course, there are controversies here. Some people will say, elite athlete, that ligament you operate. The athlete was not very ready for a surgery. And of course, doing surgery for the PCL can lead to various other problems. So I actually managed her conservatively using knee braces, different types of knee braces. And I just spoke to her last week. She's now in US on a sports scholarship, playing football in one of the sports universities in the States. So it doesn't require a surgery. But there are instances that you need to do it, right? So there is a role for conservative, there is a role for surgical intervention. Now, these are some of the components of musculoskeletal rehab. Mobilization versus immobilization. We spoke about this in the previous slides. We try as much as possible not to strictly immobilize a joint. If we have to, reduce the time span so that it doesn't cause other problems. We try to mobilize early, again taking the ankle sprain into perspective. We want to prevent that motion, but when the patient's swelling is down, the pain is down, you can allow some amount of this motion in a controlled manner. You don't want that motion. So it's not a one rule fit for all. Every injury is different. It all depends on what you get. Again, ankle injury, when we talk about ligament sprains, there are various grades to it. Grade 1 is usually just a simple sprain. Grade 2 is partial tears, and grade 3 sprains are complete tears. It holds good even for tendons. Now, for ankle ligament sprains, there's enough evidence to suggest in the outside ligament, even if it's a complete tear, the first role of management is rehabilitation, not surgery. If rehab fails, and there are criteria that we look at, if you haven't achieved optimum results with rehabilitation, then surgical intervention is imperative and you have no choice. So All that is done through a very graded rehabilitation protocols based on phases. Then, of course, muscle activation. So you try to activate the muscle almost immediately. There are various ways of muscle activation. I will try not to go too scientific in this, but there is the first step is called isometric activation. Isometric means trying to activate the muscle without change in muscle length. Hence, you contract the muscle without moving the joint. So, for example, if we put our legs straight, we will be able to tighten our quadriceps muscle without moving the hip or the knee. So that is something called isometric activation. It's step one to activate a muscle which is already inhibited. And it builds some amount of strength to allow the limb to have some amount of control. And from isometrics, then you progress as the rehabilitation goes. I told you range of motion, very important, obtaining flexibility, muscle conditioning. A lot of times I come across people who have a concept that when we speak about muscle conditioning, the first thing is carrying weights to build muscle strength. It's not just that. Sometimes they even say, okay, I need to work on my flexibility so I don't get a stiff muscles. And many times people stop at these two. Strong, flexible. But what people fail to look at many a times is endurance component of the muscle. You will come across, I have come across many people who say, I go to the gym. You have strength, you have good flexibility, but your muscle gets tired very fast because you don't work on endurance. So when we talk of conditioning, we have to look at all three components. When we do the entire rehab, balancing, of course, functional trainings, maintaining fitness, sport skills, and the psychological aspect of things. I have a lot of young patients that get injured and then come and see us. Nazri would probably agree with me too. And then they say, tak mau main lagi. I don't want to play anymore because I'm scared. So a psychological component to this is very important. So during the rehab process, we try our best to get into a patient's head in a good way to tell him that, okay, now you are ready to go back. And then you don't just, I never send my patients back to pre-injury activity straight away. If playing football, I will tell them to first start by just kicking the air and then kick the ball to the wall. So you gradually build his confidence before sending him to the field. Straight out, it doesn't happen. They won't go because of a fear factor. What about injections? All kinds of injections are available out there today, ranging from steroids to hyaluronic acid injections, which are those gel injections that people frequently give into the knee, PRP injections. Dextrose is simply glucose injections, stem cells. I personally believe there is a role for each and every one of it. Stem cells, I don't do much, so I'm not the best person to speak on stem cells, but I do the rest. There are times that we give steroids. So if I have a patient who has a flare-up of an osteoarthritic knee, who has underlying rheumatoid arthritis, in those patients, steroid is perhaps the best option. Then you got your hyaluronic acids, your PRPs are PRP is basically withdrawing the blood, then it centrifuges to various different components, and then you give a component of the blood which is centrifuged with the aim of delivering growth factors. Today, there are various types of PRPs available, just growth factor injections alone. Maybe some of you would have heard of exosomes injections and whatnot, and I have no idea what else they are going to come up with over the next 5 years. So it just keeps evolving. There is no end to this. Which is best, which works, the truth is nobody knows. There is a role for each of it. and it is decided based on the injury that we see, right? So I have my share of experience in dealing with PRPs. I'm not going to promote anything, but I have my choices on why I use what I use. And it always is backed with whatever scientific evidence is available out there. I just had a patient last Monday who came and saw me with a quadriceps tear, and he was in a lot of pain. Gave him the different options. So today, I don't believe in the term that doctors are God. We are not. We don't tell you what to do today. We tell you the available modalities involved. We go through them together and we make a decision together as to what could be best for you based on what's comfortable for you, right? So spoke to the patient. Patient wanted to recover fast, was insisting that we do an injection, and it was one option. So I gave him a PRP using ultrasound into the tear of the muscle. Spoke to him yesterday. It's day 5 now, and he's relatively pain-free. But it's not pain-free doesn't mean he can go back to his craziness. But now I can step up the rehabilitation, and what that would possibly taken him 4 to 6 weeks before, today I probably can send him back out in 2 to 3 weeks. So there's a role for each, but not every tear will need an injection. So it all depends on what you present with. So this is just sharing some cases that I've had in the past. This is a lady in her 40s who presented with severe shoulder pain, that she could hardly move her shoulder for about 2 months. And when I did the x-ray, you see that funny white thing up there. It's actually a calcification within a tendon, right? So I did an MRI as well. I won't show you the MRI image, but I will show you what is necessary for my presentation. So this patient had a calcification in one of the rotator cuff tendons of the shoulder. When I put the ultrasound, so that big chunk that you see here is the rotator cuff. This white thing that you see here is the calcification. One of the options of treatment, if physiotherapy fails, is surgical intervention, right? But when we spoke, she wanted to go all out conservative. So I put this ultrasound, with the ultrasound, I put a needle in. I went into the calcific spot, broke it, and within 4 weeks, she had full range of motion. Within 3 to 4 days, she was already able to sleep at night. And it kept improving. And the x-ray of the shoulder 2 months after that is not there. So I think if you do a surgery, go in, cut here, cut there, remove this. I don't think, I discharged her after 2 months actually. After 6 weeks, she was already completely fine. So I don't know whether a surgical intervention could send a patient and discharge after 4 to 6 weeks. But I'm not saying that all calcification, this will be the outcome. There are times that it won't be so straightforward and you will ultimately require surgery. This is another patient that I had with frozen shoulder. That was his range of motion of the shoulder when we saw him. So using an ultrasound, we went in a part of the shoulder, we injected. There was still a lot of pain. Then what we did is, again, using the machine and the needle in, there is a nerve down here. We blocked that nerve. And immediately after the procedure, this is what we got. Straight on the spot. So it makes life very easy for even our physiotherapy colleagues, because now the patient is relatively in minimal pain. So it's easy to rehabilitate the patient. The therapist's biggest problem is when there is pain. How much can you do when there is pain? And you want to push it through pain, leads to muscle inhibitions. So it becomes a problem. It's like the cat chasing the tail and going round and round and round, but not getting to any proper targets. Now we have all heard of something called carpal tunnel syndrome. So in the past, the option was just go in, surgery, cut it off. Today what we do is, this is a patient that I had who was not keen on surgery. She had moderate to severe carpal tunnel syndrome. For the last 1 month, every night she takes Celebrex to sleep because of pain. Yet she says she wakes up after 3 to 4 hours. So, of course, I told her if she wanted, she could go for surgical release, but she was not keen. So I put the ultrasound, that's my needle. I went in and what we call a hydro dissection procedure, where so this white line, this thing that you see is a tissue that covers the nerve. So the needle goes in, I opened up from here to here, dissected that whole area, and immediate pain relief. It's all done as outpatient, no OT, in a sterile manner with local anesthesia. So if possible, the pain is not so bad that you will need general anesthesia. Most of it is done, whatever that I've showed you here is all under local anesthesia. They come in, they do, I observe them for a while and they go back. There is no admission required also for these cases. Opened up, immediate pain relief. That next day morning, she sent me a message and said, I slept like a baby after 2 months. And I spoke to her last week. It's been 2.5 months now, and she's perfectly fine. I'm not saying that I can solve a problem indefinitely. There's always a risk of it happening again. Having said that, even a surgery is not guaranteed, because even after a surgical release, you can have tissue scarring that can irritate the nerve. So I have a patient that I've yet to do who had a carpal tunnel release now with tissue scarring, and the symptoms are back. So what do you do? So I'm going to go in and use this technique and try to dissect the whole scar tissue and then see what happens after that. So today, conservative management is so much ahead, and we can manage quite a number of things without surgical intervention. I don't really have pictures for a lot of it, but my friend Kunalan, he's an arthroplasty surgeon, joint replacement, one of the top around, who sees very bad cases, and sometimes cases that he sees are patients not fit for surgery. He gives me a call and he says, bad knees, a lot of pain, patient can't undergo surgery, can you do something about it? So I see the patient, I target certain nerves, I block the nerves, and then ultimately I do some procedure called radio frequency ablation, which is something like burning the nerves that cause these problems, and patients can remain, I'm not going to say pain-free, although a lot of people use the word pain-free. I don't think it's pain-free, but 80-90% relief of symptoms. Ultimately, it's getting the patient comfortable to be able to be independent and perform most activities of daily living comfortably without a problem. So there is a role for this, but ultimately it's never indefinite. The patient, the symptoms will come back after a year, maybe 2 years, and then we'll probably have to repeat again in the event the patient is not a candidate for surgery. If the knees are bad and the patient can undergo surgery, then I think a knee replacement, whether it is one side or full knee replacement, partial knee replacement, or a complete knee replacement, may be still a better option, because it has a way longer lifespan than all these injectable procedures that we can do. So it all depends on the type of case that we get. In conclusion, non-surgical treatment for sports injuries is constantly evolving, and it challenges us as well, because more and more innovative techniques are coming up. When I attend conferences, uh, overseas, I'm always mind blown with new things that I keep seeing. So I don't know in 5 years' time what's going to happen. I was just having a joke with a colleague on Friday, and I said at the rate AI and robotics is coming into this world, if we may all be out of jobs one day, right? So, including the medical field, yes, we don't know, right? Where we are going to head. Of course, today we can say no, it's a skill. You won't be, you, nothing will happen. But I don't know. So, like I say, right? It started with hyaluronic acid. Suddenly, PRP came, then secretomes, then exosomes. Don't know what is happening out there. So it's a constant evolution that we are constantly learning, and ultimately, it is for the betterment of the patient to try to help them in the conditions that they have. So that would be the first part of my talk. Am I overshooting too much? Right? Now the next one is exercise in chronic diseases, or otherwise called non-communicable diseases. And non-communicable diseases is a big problem globally. One of the biggest burden on the healthcare is diabetes, right? So it's lost lasting, and many a times it cannot completely be cured, and it's all about controlling the disease and reducing the complications that can come with it. Now, exercise has been shown to have a role to play in almost all of these chronic diseases, where they can improve health outcomes, take care of the emotional well-being, and ultimately the goal is always enhancing and improving quality of life. Now, there are various different types of exercises that are available out there, from aerobic exercises to strength training and flexibility balance exercises. Various different types. Aerobic exercise are basically what you may say to help you build your cardiorespiratory fitness. And examples of it would be cycling, would be swimming, would be jogging and whatnot. Strength exercises is strength exercises, building muscle strength, whether it's using free weights, whether it's using gym equipment, or whether using exercise bands. And flexibility exercises, which is all about stretching. Now, there are various different guidelines that have been designed for different types of non-communicable diseases. I am again unable to go through it in detail one by one. It's beyond the scope of this talk, but I have kind of summed up some of the guidelines recommended for the different conditions. For example, in heart disease, you do low to moderate intensity aerobic exercises which are recommended, such as blah blah blah. In diabetes, so we read this all the time. It's all available on Google. But the great question is, what the hell is aerobic exercise? What do you mean by low intensity? What do you mean by moderate intensity? How long do I need to do it? What can I do? Nobody tells you these things. Hence, this is where we try to play our role by clearing this taboo or doubts that a patient may have, right? We always hear, you go and see a physician, the physician will say you need to exercise. How much to exercise? What do I do? What can I do? How often do I do it? How much can I do it? These questions are never answered. And then ultimately you will be told, just go for your evening walk, it will be good. It's not enough, right? So we try to objectify, to be specific in these exercise prescriptions. Now, later I will take one of these, which is very common, which we see all the time, diabetes. And we try to look a bit more into diabetes a little later. But before we progress, let's a very simple definition of exercise intensity. How do we do it? We just have to take 220 and minus our age, right? So that will calculate your maximum heart rate. It's a very simple calculation. There are various formulas involved. There are various different ways of calculating this, but this is one of the easiest. For example, if you're 40 years old, 220 minus 40, your maximum heart rate would be 180. So if you want to do a low intensity exercise, you target 35 to 50% of your maximum heart rate, which is 180. So I am a doctor for a reason, because my math sucks, so I can't calculate 35% of 180 is how much, but 50% would be 90. So you are looking at trying to maintain your heart rate within 35 to 50% of that 180, and that would be low intensity exercise. Moderate intensity is 50 to 70%, and vigorous or strenuous exercise is more than 70 or 75% of your maximum heart rate. This is just one very simple technique of calculating exercise intensity. There are various methods available. There are methods which are more accurate, because this will not hold good in someone who is fit. We can use it if someone is starting exercise, just as a guide. How do you monitor your exercise? Today, the watches can do the job. In the past, you have to wear a strap and calculate and all that. Today, your watch will be able to allow you to check your exercise intensity, right? You can use heart rate reserve, where you calculate based on your maximum heart rate, your resting heart rate, and there's different formulas called the covenant formula and all that. I won't go into all these details. Like I said, it's beyond this, but there are methods of doing it to get a more accurate representation of what heart rate I need to maintain to have the best outcomes. Having said all this, nice to talk, nice to know, but I always tell patients, just start exercising first. Start first, and then we get into the details. So if I go into the details at the beginning itself, you won't last 1 week, right? So you start somewhere low, and then motivation is a big problem that I have too, right? The reality is motivation. If you can be motivated and be disciplined to do it consistently, then we start exploring this and going into the necessity. So for the simple, relatively comfortable intensity of exercise usually falls in this moderate intensity exercise. And today, what the recommended guide for maintaining a healthy lifestyle is 150 minutes, 150, of moderate intensity exercises per week, coupled with strength training 2 to 3 times per day, and addition of flexibility exercises 2 to 3 times per week. It's tiring to even say it, so you can imagine doing it, right? So 150 minutes a week is simply 30 minutes per day, 5 days per week, right? But this is only to maintain a healthy lifestyle. So for non-communicable diseases, you want to achieve something for exercise prescription, the recommendation is 150 to 300 minutes per week. So you are looking at 30 to 60 minutes of moderate intensity exercise per day. Of course, once moderate intensity is achievable and you are very comfortable and you want to up the game, you can up the game by moving to vigorous intensity exercise, and the requirements are pretty much half. 75 to 150 minutes of high intensity exercise per week. It's good enough. Again, science is continuously evolving. I don't know how many of you here would have heard of HIIT, H-I-I-T, high intensity interval trainings. So that is also has come in, good exercise modality. Never try it as the first, as you start, because the next day you'll have aches, tired, fatigue, and then you will not do it again, because it also happened to me, right? So start somewhere and then explore it. Now, as usual, life is never so simple. If we look at diabetes per se, as an example, what type of exercise you can do. There are various exercises that we explored just now, from aerobic exercise, strength training, flexibility exercise, combined aerobic, flexibility, strength training, high intensity interval training. So you see, there are various different types. So the question is, which one? Next, the duration of exercise. How long do I need to do it? So we went through it just now. For diabetes, the recommendation would be 150 to 300 minutes of moderate intensity exercise. Exercise intensity, we already went through that. Blood sugar monitoring. So in diabetes, this is very, very important. When we start an exercise, immediately for the initial phase, you can have something called stress hyperglycemia, where the sugar will shoot up, right? And as you exercise, the sugar falls down. So there are ranges that you need to monitor. When is it safe for a diabetic to exercise, right? If I were to simply put it, if your sugar is less than 5.5 millimoles per liter, no exercise, because it will suddenly crash. So you will need a carbohydrate diet before you actually start. If your blood sugar is more than 13.9 millimoles per liter, you need to check for urine ketones. If the ketones are available, postpone the exercise. No ketones, you can do the exercise. If the sugars are more than 16.7 millimoles, whether there is ketones or not, you might want to postpone the exercise, because you don't want to land up in a very high sugar state when you immediately exercise. So monitoring blood sugar is very, very important. It's not just that, but for someone, a diabetic who is going to exercise very regularly, there may be a situation where you will need to modify the medications you are taking as well. So if you are the type that is going to practice early morning exercises, there may be a consideration of reducing the previous night insulin doses by about 20%. So please don't go back and just do all this on yourselves and end up in trouble and then say I said it. No, what I'm trying to tell you is it's very individual based, right? And this decision has to be made with your medical practitioner. And sometimes even for me, I will speak to the endocrine doctor who is seeing the patient. So we work together. It's a team approach. If especially you need to modify the medications. There is a type of diabetic medication called sulfonylureas, the glibenclamides and whatnot, which are longer acting. You need to be a bit more careful if it's in this compared to metformin, because of how the medication works when someone is going to be doing regular exercises. Then precautions to be taken. We know diabetes can cause various different complications as well. So if a patient has diabetic neuropathy where the peripheral nerves are affected, so you can't do it like a diabetic patient without that complication. So in those individuals, you want to avoid too much of weight-bearing exercises. So you modify it to perhaps cycling. You don't want too much of vigorous weight-bearing exercises, because you will not be able to, these patients will not be able to feel if the feet gets injured. And then you have those problems. Diabetes with retinopathy, eye problems. You want to avoid vigorous activities or too much of strength training that involves movement above the head. Likewise, nephropathies, those with kidney conditions, the exercise prescription differs. So, having said that, in diabetes itself, as much as a simple guideline on this slide, it's not as simple as that, right? So even for heart disease, there are various different types. If you undergo coronary artery bypass surgery, different type of exercise prescription. With the sternotomy, they remove the bone. Without it, When do you start? So generally it said you can start low intensity exercise after about 2 weeks, but for about 3 months, try to avoid upper limb exercises and do more of lower limb exercises to allow healing to happen. So it's very specific based on recommendations and guidelines which constantly evolve with time. So what we can say, as I've mentioned it again and again, there are no hard and fixed rules to exercise prescription, and it's very individually designed. Now, when we integrate exercise, it has to be a holistic thing, as I've mentioned. Various different things you want to look at. It's very individualized. We need to also explore behavioral modification techniques. It's no use we do all this, yet we consume all the ice creams and chocolates in the world. So there needs to be behavioral changes as well, multidisciplinary collaborations. This is a study which was published about 8 years ago. They took 43 individuals that ranges about maybe 60 to 70 years old or whatnot, that's the mean age, and put them in a community supervised exercise program consisting of combined aerobic, resistance, agility, and balance exercises 3 times per week, 70 minutes per session. It's that protocol that they created, and ultimately they reassess the patients again and notice that this group had improved aerobic fitness, muscle strength, and balance, telling us that it is important. We know it is important. So we need to do what is necessary. All right, with that, thank you. That QR code there, you can take a picture of it, and there are links in the QR code to my YouTube channels, to my place of practice. So in the event, I'm not here to promote service, we are here to talk on these topics, but in the event you need to ask me anything or come and see me, you can do it from the information that is in the link that is attached with the QR codes. Plantar fasciitis is generally a conservative treatment. There is very minimal role for surgical intervention. So ultimately, it is rest, medications, calf stretches, plantar fascia stretches, electrotherapeutic modalities, can be shockwave, and other modalities that the physical therapy may help. In a more prolonged case, you might require a steroid injection or a PRP injection as well for plantar fasciitis. Ultimately, there is a misconception that if I got calcaneal spur means it's plantar fasciitis. No. The calcaneal spur is not synonymous and causing the problem. It just tells us the chronicity of the problem. Because the tissue is tight, it's pulling on the bone, a spur forms. So going in with, because I got calcaneal spur, I cut the spur, I'll be fine. No, it's not as simple as that. It's addressing the soft tissue problems and why did we get it? Whether is it a flat foot, and hence we got a plantar fasciitis. So treating the plantar fasciitis without addressing the causative factor is going to lead to failure. So you may want to correct the arch, whether the shoe you are wearing is adequate or not, are proper shoes or not, is it worn out or not, and whatnot. And then is it really plantar fasciitis? A lot of people think heel pain, plantar fasciitis. It may not be. It may be something else called fat pad syndrome, which happens on impact.